If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Highway to Health podcast, hosted by Jeremy Quinby, provides guidance, quality resources, and inspiration for anyone seeking wellness in mind, body, and spirit. There's an episode that you should check out called The Value of Our Emotions, where Jeremy helps listeners understand the role emotions serve and what we can learn about our present state by staying attuned to them. Check out Highway to Health podcast on your favorite podcast platform or visit healthpodcastnetwork.com.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Hi everyone, this is Dr. Raj Sundar, and welcome back to Healthcare for Humans. As a family doc, I've watched our healthcare system evolve and sometimes struggle to meet the diverse needs of our communities. This podcast often focuses on the history and culture of different communities. We've done some deep dives into research topics and specific concept-based episodes like the power of language. Today, we're diving into something that is important for me and an important piece of the puzzle about how do we deliver culturally responsive care. We're going to be talking about value-based care. A lot of you probably have heard about this, but it's an important piece of this puzzle because a question that I often think about is how do we balance the push for value-based care with the need for truly community-centered healthcare? Let me share a recent experience that really drove this home for me. I was explaining to a colleague how our clinic operates under a value-based model, getting paid for outcomes like blood pressure control rather than just office visits. So when somebody gets their blood pressure controlled or we control their diabetes, there's some incentives, then we get extra money. In healthcare, so much is about money. This is different from how traditional fee-for-service model works with billing. So every office visit that you bill for, according to RVUs, which for all my clinicians out there, you know what I'm talking about, you get more money. So the value-based system is different from the fee-for-service in that we are focusing on value. The colleague then asked me a simple question that stopped me and made me question the language I was using. He said, valuable to who? I wanted to say, to my patients, but the truth is more complicated. For many of the families I serve, especially in immigrant communities, their definition of value often looks different from what our systems measure. It's not just about if you have diabetes, did we control your A1C level, which is what we in healthcare system think of as valuable, because we're preventing heart attacks and strokes, right? For my patients, though, it's more about what it means to actually live life, whether a mother feels well enough to care for her children, or if an elder can participate in community events without pain. It's about dignity, cultural understanding, and holistic well-being. If you're a practicing clinician, you know this and feel this every day. This tension between system-level metrics and community-level needs is at the core of today's episode. That's why I'm thrilled to introduce our guest, Hiroshi, today. Hiroshi brings a unique perspective, having worked extensively in both community health centers and large healthcare systems. In our conversation, we'll explore the evolution of community health centers and their patient-centered approach. For instance, innovative programs like a community bike center that one health center used to address diabetes in a Polynesian community. 2, the shift towards value-based care, what it really means on the ground and why it matters. 3, the challenges of defining value, quote unquote, across diverse communities, and how to ensure equity is prioritized in these new models. This episode is for you if you're a healthcare leader grappling with system-wide changes, or a clinician trying to advocate for your patients within larger systems, which more and more people are part of now, or a community member interested in understanding how healthcare is evolving. I encourage you to think about your own experiences. How have you seen the disconnect between healthcare systems and community needs play out? Let's jump in. Here's Hiroshi. Welcome to the show, Hiroshi.
Thank you. Thank you for inviting me.
Tell me about yourself and how you got involved in the work you do. and what you're involved in right now.
I work at Valley Medical Center, and I do all things related to healthcare reform, payment reform, and specifically how it impacts health systems. We're involved in a lot of different contracts with third-party payers, and I'm responsible for the performance in those contracts, specifically how it works at Valley Medical Center. And then independent of that, we've gotten involved in things like the Medicare Shared Savings Program and the Bundled Payment Program. And then really the care transformational part is actually the more interesting part to me of working across the organization of how do you change the culture from a fee-for-service oriented institution to a more value-based institution. And so I get to work with a lot of really great people across from primary care to inpatient to case management, and trying to really figure out how to better serve that patient as they go through their interactions with us and back out into the community. That's another aspect of my job that's a lot of fun, is working with different community-based organizations and creating stronger partnerships. Healthcare has traditionally been refer the patient to so-and-so because they have a need for income support or some sort of community support. What we're trying to do now is create more of a two-way dialogue between that community organization and Valley as a health system. And how do we better track the progress of that patient? How can we refer patients back and forth to each other and get just a better knowledge about the services they provide and the services we provide? Background-wise, personally, I'm Japanese American. I'm Sansei, so a third generation. I grew up in the Tacoma Buddhist Church. So I'm a Buddhist by background, and that actually has some influence as to kind of how I look. Shortly after graduating from high school, I went to Whitman College for a couple of years and actually had a name change. So my full name is actually Hiroshi Wayne Nakano. And growing up as a kid, my parents decided that I should use my Americanized name, Wayne. If you talk to people that knew me from high school and earlier, they know me as Wayne. And then if you talk to people from college forward, then they know me as Hiroshi. So
A true identity change there.
It was pretty conscious. I thought as a kid growing up, the name Wayne just never resonated with me for a variety of reasons. And so with time and interactions with some folks that I'll talk about a little more deeply, I really wanted to use my Japanese name. And so I thought when I went off to college and I left the area to go to college, it seemed like the right time to make that identity change. And so it's been an interesting journey. Some people like it, support it. I've had people not like it, which was really interesting. When I was in grad school, I was dating Chinese woman that grew up in Chinatown in New York City. And I went to an MBA program into an Ivy League college, and everybody's looking for, at that time, a job on Wall Street and that type of thing. And she said to me, maybe that's why she's an ex-girlfriend. She goes, if you use the name Hiroshi, they're going to think you're a boater, with the implication that's going to hurt my career chances, right? And I thought about it and I went, you know what? If they have a problem with my name, I don't think I want to work for that company. But it's interesting the types of reactions that people have when you're talking about your ethnic identity and how you want to display it to the world. And sometimes not everybody's really supportive of it. There was a situation at work one time when I was telling the same story, and there was a woman who ended up having a very Americanized name because she was adopted into a white family. And she's Polynesian by background. And then when I told the story, it seemed to click with her in her own sense of identity. And she went back and basically took on her ethnic name. And I thought, wow, that when you're talking about story and the power of a story, that was really powerful for having somebody to say they recognized the journey I had in terms of my own ethnic identity, and for that to resonate enough for her to go back and say, this is who I want to be to the world now.
Yeah, thanks for sharing that, Hiroshi. I really appreciate how you, I think, in your growth has said, no, I am Hiroshi, not Wayne. And I'm going to work for institutions that support that identity and what I bring to the table.
Yeah, no, that's exactly right. And it's been an interesting journey. I'll mention an ex-sister-in-law when I was in high school. My brother got married, and she was quite the community activist. And she really started informing how I could take my own journey in terms of figuring out who I was, how I wanted to present myself as a Japanese American, third generation, and how do you really then do something related to the community? And what's the role of the community? There are lots of times, I think, when you're talking to different folks that grow up in the Asian American communities, where you hear stories of a lot of isolation and not knowing what it meant to be part of an ethnic group until later in life. With me, being part of the Japanese American community in Pierce County, we were surrounded by Japanese Americans. It just seemed normal to be Japanese American. And frankly, I have always thought of it as being an advantage. Even though I knew discrimination happened, being in sports, crowds calling you a Jap, stuff like that, that was a semi-common experience. But again, having an ethnic identity, I always felt like it was an advantage because it grounded you, you knew what was happening, and it also differentiated you in a positive way in my mind. And so with my ex-sister-in-law, because of her connections, really started exposing me to what other possibilities existed. And she was a big influence in terms of my involvement in community-based organizations. The University of Washington's had a program out of health sciences where they were trying to get BIPOC community members, students into health administration track, as opposed to typically the focus in health services has always been on provider tracks, being a doctor, being a nurse, that type of thing. And this program was different because it was basically a leadership development program. And so we took a couple of classes in healthcare and we got assigned to a preceptor at a local health organization who was part of the program. And I was assigned to a health insurance company. My preceptor was the head of HR, and she and her husband at the time were really engaged in community health centers before there was a federal program. So we're talking really volunteer-based, scraping together funding to try to pay for doctors, pay for nurses, those types of things. And that was 40 plus years ago when I first got involved. And so my healthcare journey and my community organization and community health center journey started there. And I've been involved with community health centers ever since.
Thanks, Hiroshi. Our listeners are often clinicians, but also people in the healthcare system, both leaders and managers, and sometimes community members. I think the idea of both value-based system and the strengths of a community health center will be important to focus on today. So I'm glad you'll be helping us understand that better. Let's start with community health centers because you talked about your journey in that space. What I respect and admire with community health centers are how the community is really centered in the care they give. Why do you think that community health centers have always viewed this as a core mission in how they provide care, providing culturally responsive care, making sure the communities are centered and designing the programs? How did that come to be, and what do you think other people could learn from that?
When you look at the history of community health centers, they exist because of people in that community saying, we need healthcare. We need to be able to provide healthcare to the people in our community because it's lacking for whatever reason, right? We're either rural and isolated, or we're urban and ignored, or that the traditional health systems in our area are inaccessible to us for any number of reasons. And so I'll take ICHS as an example, where people in the International District of Seattle saw a need for, at that time, immigrant Chinese, immigrant Filipinos who didn't have access to healthcare. They didn't necessarily have family support because of their immigration status, and were living in low-income hotels in the International District and had no real access to healthcare. So it was a group of community activists who just said, we're going to change that. And started with a volunteer clinic 1 night a week and basically grew ICHS into what it is now, which is a mainstay health institution in the community. I think that's why community health centers are so centered in the community. It's not so much there was a big policy initiative by the state or by the feds saying, you know what, we should get our communities more engaged in the healthcare, which is the way that a lot of people think about it. And I think traditional healthcare institutions think about it is, how can we make better connections with the community? Community health centers, they are the community. There's really no differentiation between the health center and who the community is, because it was born by the community. And that's been formalized when the feds and some leaders nationally decided that we need to be able to fund these entities called community health centers. And they made it into a federally qualified health center program. By law, the governing board needs to be 51% patients. I don't think there's any other organization out there outside of community health centers, at least formal organizations, that have 51% patients as part of their board. You start seeing that a little bit in the Medicare Shared Savings Program, where they require that you have a Medicare beneficiary as part of the governing structure, right? But when you talk about 51% patients directing the care that health center should be providing in the community, it makes a big difference. Your whole mindset is different than when you're thinking about the governance of a large health system.
Is there hope for other care systems when they're not fundamentally structured that way? Because you're right. I think we think of questions about community-centeredness from this us and them perspective of how do we get community involved? And maybe we can involve them in some decisions while we make some other decisions. But this community health center model is totally run by the community. What does it mean for next steps for these other systems or people working in different settings?
Yeah, that's a really interesting question. Currently, I work at Valley Medical Center, which was the public hospital district in the state of Washington. It has an elected board of people from the community that's board of commissioners, 5 members. That's one model, and I think that's what differentiates public hospital districts like Harborview or other critical access hospitals across the state and the country, where it's similar in that the governance model comes from the community. In other institutions, that's not true. I think in the majority of health systems, that's not true. There's different policies that are starting to change that now, with the recognition that we need to be able to address health inequities in our communities. That's part of your responsibility as a nonprofit, right? I think that's starting to get built in programmatically and legally. That's one way to do it. Unfortunately, then that leads some people to think, or some organizations to think about it from a compliance point of view, which is not really the intent. It's not a check the box exercise in terms of if you're really trying to say we need to be more in tune to community need. So I think best intention is you just need to be present. I think about that quite a bit. Part of my job now too is overseeing our equity, diversity, inclusion program. And when I think about what would really make that work, I obviously go back a lot to what I've learned with community health centers over the years. And I think one of the lessons that community health centers can bring is, how do you really address community need? I've been lucky enough to visit health centers across the country, and every one of them is a little unique based on whatever the needs are of that community and what's the composition of that community. And there's a really interesting program in one health center in the state of Hawaii where they built a biking center. And one of their staff people was a professional bike rider. And so he had access to a lot of resources in that industry. And in this case, they were focused on the Polynesian community, which has problems with diabetes and hypertension. And they wanted to do something after school with a lot of the kids. So they built this bike center, and then they started integrating nutrition. They started integrating exercise and fitness, and they started getting really great outcomes with the kids. Then the motivation was, you learn how to build a bike, you learn how to maintain a bike, you get to keep the bike. And it ended up being a really successful model. And I learned a lot from that observation about how you just build programs, sometimes feeling very organically out of what the community perceives as its own needs. And then, can you make it sustainable? Can you build upon that? Can you replicate that? I think the health systems need to really listen more to what the community is saying is that they need, and then try to start designing toward that and being present in that exercise.
Yeah, there's a sense of for us, by us. I've witnessed so many community gardens, part of community health centers, and this example of autonomy of owning the bike and getting children involved, getting this whole community and family involved. It clearly seems like the community determined this is important for us and this is how we're going to do it. As a leader, sometimes I think of it this way. I'm curious on your thoughts of, my job is facilitating these ideas and then being in the other rooms advocating and sponsoring ideas that are truly from the community. And in those conversations, sometimes what I struggle with is, one, the business case of, hey, is this actually going to make money? And the second question of, does it scale? Hey, can you make this happen in other places? I struggle with both of those because the business case, because sometimes it's hard to quantify what the joy and well-being the community is getting, the engagement, autonomy, feeling like this is ours. And the second part of the question about scale is also hard because this could be contextual for that community. And every community needs to do that. It's not that we need to now make the bike center efficient and then create a model and then have every community have a bike center where the kids come in and fix their bikes. But that's the existing healthcare paradigm. I'm curious on, how do you address those two things?
Yeah, that's a really good question. Because I think that traditional healthcare thinks about sustainability as a growth model, right? It thinks that, if it's not replicable, why bother? And I think a lot about that from, not so much from the health center point of view, but from the payer point of view, where they're looking for solutions to the cost of care, how to improve quality, those types of things. And they may be like a statewide insurance company like a Regence or a Premier or something like that, versus a national company like United or Kaiser or Cigna, where they're trying to find something that works, that really helps us control the cost of care and improve quality and improve member experience, and then replicate it, right? So we can find something to replicate. And I think that's a lot of where that viewpoint comes from, is really on the financial side of the world and healthcare, where we got to solve this, right? Growth and cost is unsustainable in healthcare. So we got to do something about it. So we got to find an answer. And it's always in the search of an answer, as opposed to looking more locally for an answer. What's the answer that fits? Maybe we don't talk about enough is that healthcare is local. Even though we all know that, even as being leaders in large health systems, the systems don't act that. The systems always act, I don't know where the solution is, but let's look at this clinic in Texas. They got a really cool thing going there. Let's see if we can replicate that, right? We do that over and over again. And I think a lot of it is because I think traditional healthcare is risk averse, right? So you almost have to prove a program before you can even get it started.
Yeah, I wonder if that's the downfall of our healthcare system, because there is a growing trend for both centralization and consolidation. And we're losing that connection to healthcare as local understanding and moving more towards what works and how can we scale. Now, I don't know how to combat that. Maybe that's a bigger question than both of us. I'm curious if you've seen any signs of movement towards that, and how do we find that?
I think that the health center movement is the epitome of that. And as it's gained credibility, you're starting to see like partnerships between traditional health systems and community health centers happening. Part of that may be self-serving for both parties in terms of financial stability, unfortunately. But I've seen cases where that actually works more in the favor of the health center in trying to address its own community needs, because the partnership can work really well if both people understand what are they bringing to the table. Because you think about a health system like Valley, we're a hospital, we have a whole battery of specialists. Community health center is looking for, where can I admit my patients? Where can I get specialists to see my patients, right? Because traditionally it's been either an uninsured or a Medicaid population for community health centers. Unfortunately, the reimbursement for that is very low traditionally, so that health systems tended to restrict the number of people that they would see with Medicaid, for instance. And so there's always that struggle between, where can I admit my patient? Where can I get a specialist to see my patient from a health center perspective? I think that's slowly changing as health systems have seen that they need to be able to partner with community health centers, because they become such a large part of how primary care is delivered in your local community, that you can't ignore them, because they're coming in the hospital via the ED or something more intentional than the ED, hopefully. So I think there's a growing awareness that these sort of community partnerships are important for both parties. And it's not just, oh, gee, I'm a hospital, I'm a nonprofit, I'm supposed to be meeting my obligation as a nonprofit, but more in a fundamental way that those partnerships can really help both parties, and they work the best if they start putting the patient at the center. What are we doing for the patient, and how do we better provide care by working together?
Yeah, centering the patient, the family, and the community. Hopefully we are all thinking of those questions. Let's transition to your second specialty, value-based care. We talked about community health centers. We talked about the strengths of community health centers and what we can learn from how they've evolved and how they center the community. Another big part of how our healthcare system affects how individual clinicians provide care is, we say, reimbursement, how people get paid. As I said, we have people from all over the healthcare system listening, including clinicians, and they're probably familiar with billing. That's probably how many people experience the end state of financial models, is billing and coding, etc. Let's see if we can summarize it for people who are still beginning to understand it. I would talk about it as a shift from volume to value. I think that was what it was initially coined. The idea is that when you're seeing a patient, if you're fee-for-service, you get paid for every encounter. So you're incentivized to see more patients more quickly, more of the time, because that's how you get paid. And the goal is to shift to a value-based system, which means that you get paid for how you take care of the patient. Are you meeting their diabetes goals? Is their A1C well controlled? Is their blood pressure controlled? So you get reimbursed for that kind of care rather than just seeing the patient. That's my basic 2-sentence summary. Would you expound on that in any other way for listeners who are still grappling with understanding this idea?
Yeah, that's a really great summary, Raj. I think the center of all that is payment, right? And that how we incentivize the type of care that we all believe needs to happen. I think the other part of it, and we've talked about it in the earlier segments with community health centers, is how do we put the patient at the middle? How do we make sure that their needs and wants and goals are expressed in that care rather than healthcare is pretty technical, right? It's very scientific. It's very technical. There's a lot to be learned. There's a huge body of knowledge. And we've designed our systems around that, meaning that we've designed the systems around the needs of the people that are providing the care. And in my mind, a little bit less about designing the system around the people that need the care. And that has certain implications, right? What you talked about earlier about the current volume-based system is the incentive is do more, do it faster, do it quicker. I think that system begins to lose a little touch around you're here for the patient. If you can't get the patient's needs addressed in that 20-minute appointment, then what happens, right? You call them back, and now you have another 20-minute appointment. And you may focus on one single diagnosis or health need, but what about the other needs? We'll call them back again, right? And you get into this weird treadmill type of approach to healthcare. I've always thought that if we were going to make healthcare more patient-centered or community-centered, we really need to change the way that we pay for it. Because the incentives are pretty obvious under fee-for-service. I always make the analogy. As a kid, I grew up working on other people's farms. And you get paid in terms of piecework, generally in farm work. The incentive's pretty obvious. The more you pick, the more you make. Healthcare is very similar under a fee-for-service world. You see a patient, you get paid. You do a procedure, you get paid, right? You have an admission, you get paid. As opposed to getting paid in a different way in which it allows for the time to really focus on what the patient needs, taking the time and effort necessary to do that in a way that works for the patient.
I like that explanation of it and your farm analogy. I'm a big believer of value-based systems, Hiroshi, but I know all the ways it doesn't work. So I think we're going to start with the idea that fee-for-service doesn't work great. So we're going to move towards value-based because it's a better model. We'll start with that assumption. I think what's hard with the movement towards value-based system, which some listeners may be really familiar with, is how we define value. Because if we're focusing on the patient, yes, they want their blood pressure controlled, they don't want strokes, they don't want heart attacks, but they don't often talk about value as blood pressure control, diabetes control, pap smear screenings. And I think as healthcare systems, we can be overly focused on the technical aspects of it. If you go to the community health center or the communities and ask them, what does a true valued healthcare system look like in your community? That's not what they're going to focus on. Yes, that's important, but they want somebody that listens to them, that centers their needs. That's more than just the technical parts of healthcare. It's actually about health. They're addressing the social isolation in our community, the trauma from racism, right? These are the real things that communities say. And I feel like the value-based system misses that. And then we're overly focused on what we define as value, leading to actually doing less because we know this is our new model. And I'm going into the weeds a bit, but I'm curious on you living this work on how do we make sure value-based systems are inclusive of different cultural beliefs, different communities, and what their hopes are for a valued healthcare system.
A lot of times in value-based arrangements, it really becomes a matter of, oh, we have to hit that target, right? It's even more than just check the box. It's more like, how do we arrange our system so we can make sure that we hit the 90th percentile for A1Cs for our diabetic patients? Not that's not a good goal, but you tend to start organizing around the measurement than you are organizing around the patient. Or at least that can feel like the incentive. And so I think it's always a matter of trying to come back and put humanity back into that work. Things like starting a meeting with a patient story and always reminding yourself, like, why are we here? Especially now that when you start thinking about the social drivers of health and making connection back into the community and what do you see in that patient as a whole person? I think we have to work really hard and really intentionally of bringing that back to all of our discussions when we're talking about value-based care. Because again, you can just do it in terms of, I'm just in it to chase the money because that's what the payers want. And so I'll work on making sure that patients come in and get their diabetic eye exam. And hopefully they happen in our institution because we'll get the revenue from that, right? But you can play the game in that way. Or you could play the game in understanding that, okay, we need to generate the resources that are necessary to help us build the systems to do a better job of patient care, of being able to afford to spend the time with the patient and to really listen, right? Part of this is also, I think, how do we retrain our staff to think in those terms? Because everybody's been trained in a certain manner. And until they see a different model or exposed to a different model, then they're going to continue to do what they know. We've developed a program of volunteer health coaches, and a major part of their training is around motivational interviewing. And personally, I'm a big proponent of motivational interviewing because you're really asking the patient what their needs are, and hopefully in a way that's respectful about their background, their culture, and how do they center their health? What's more important to them? We had a patient that was being assisted with a health coach, and their biggest thing was they had a pet. She was looking for a veterinarian. Once the health coach helped her achieve that goal, then they were able to start saying, oh, what about your A1C? And what about how do we better manage your diabetic? But it all started with the patient understanding that their goal was most important. And then once they were able to achieve that goal, then they started realizing, wow, I could start doing other things to help myself. But it was really motivated by helping her pet. We hear those kind of stories over and over and over again, right? So it's not about starting off by saying, Mrs. Smith, your A1C is too high. I'm going to start you on a course of insulin to help you do that. And oh yeah, by the way, you should probably go see the nutritionist and you should get more exercise. So why don't you start walking around the block more? And then when they come back, and because there are other things that are more important to Mrs. Smith in her life than just herself, she comes back in the follow-up visit and she hasn't done any of that, right? So what help have we given her?
Yeah, there's so many stories like that. I resonate with that, of making sure we know what the patient's goals are and what's important in their life, like you said, a pet. And if we're able to meet them where they're at, then we can help them with our value-based goals as well. I'm curious on also, how do we ensure that equity is prioritized in these models? Because you could set a metric of A1C control or blood pressure control, and on average, it looks great, but there are certain communities that are left out. The one question is, how do we recognize that? And the two is, there's so much complexity around how communities are named. Are we talking about the Asian American community or the Khmer community? We're talking about Black community. Black excluding African community or Black with Ethiopian, Somalis, etc.? Like all of that complexity?
Yeah, pretty complex question. Probably a pretty complex answer. I'll try my best. Where do you start? You just begin, right? I think that obviously it's a multifaceted approach, but I'll try to outline a couple of things, I think. One, it starts by just being present in the local community, right? And having a better understanding as to what the health needs are. You can do that by conversation. You can do that by outreach. You can do that statistically, like Seattle King County Public has a really good set of statistical measures that are both broken down by race and language and some other things. There are policy initiatives that are happening at both the state and federal level to try to bring equity into our decision making and into those models. But I think a lot of it just starts by understanding who your community is. And again, you can do that a couple of different ways. You could do it by conversation and engagement, or you can do it statistically. You're trying to measure by asking patients what their ethnic background is or what their primary language is. And then you start understanding who are the patients coming into my institution and who are we taking care of? And then start stratifying different measurements like A1C or blood pressure or did somebody get their immunization or their mammogram. I think it takes a combination of all those things to better understand what the needs of the community are. So you need to do those kind of simultaneously. And a lot of that is what your commitment level as an institution is to be able to address those things. And it's not easy. Like when you talk about the different sets and subsets of immigrant communities, I think like in South King County where I work, we're providing services in something like 100 different languages. And then you think about trying to break down each of those sets in some sort of quantifiable way that you could actually take action on. Not easy, especially when you're trying to be respectful with patients in terms of asking these questions like, what's your ethnic background? What's your primary thing? What's your income level? All these different things that we're trying to get a handle on. And people have the right to say, no, I'm not going to tell you that. And so I think the engagement part with the community is so important because have you established a level of trust where they feel comfortable telling you that? And maybe that's where it all comes down to too, is like, is there trust between us as healthcare providers and the community that we serve?
Yeah. Has there been any specific challenges that you faced trying to integrate with community-based organizations or communities in the care transformation work that you're doing?
Yeah, there's lots of challenges. There's, why should I talk to you, right? Eligibility is a huge problem. And then the complexity, I think most people don't really understand the complexity of just, are you eligible for a service? Are you eligible for a benefit? And how does that manifest itself in one organization versus another? But I think that's where putting the patient at the center really helps expedite those conversations, because that's the commonality, right? Whether or not we're a community health center or a community mental health provider or a food bank, the reason why you're talking to each other is because we have patients or consumers in common. And we're all trying to do a better job helping that patient improve their health.
Yeah, I like that. Our people are the same. So let's start there. Whatever entity that's in the community, our people, meaning who are customers, clients, patients, constituents, whatever that is.
Yeah, because I think that's really where it all starts. I think if there's any message for this podcast, is that if this is important to you, if equity in healthcare, if solving health disparities is important, start in your community.
Thank you, Hiroshi. Any other takeaways?
I think the message would be just please do it with all good intention. Because I can also tell you that the community knows when you're coming in for your own self-interest, right? One of the problems I think that we all bring when we're talking about community engagement is that we look at the community from a deficit point of view, as opposed to really understanding that there are huge strengths in the community. And I think the conversation changes a lot when you're thinking about that the community has strengths and to lead with those strengths, as opposed to thinking we're the health system, we're the provider of care, we know better. So we're going to attack deficits in the community, right? And so knowing that communities have strength and the communities themselves know they have strengths, right? And so when you come in with a deficit mindset, they know that, and they know that you're treating them as lessers. So I think having a more humble approach about you don't know everything as a health system. You have patients in common, you have a community in common, and there are issues to tackle, and we can do it better together.
I love that. Intention matters, because I can vividly see the manifestation of this. Hey, I'm looking at my metrics. Our diabetes care isn't great for this community. Let's go in and figure out why they don't care about diabetes and why they're unhealthy. And then let's fix it for them, right? I feel like that you can unintentionally fall into that. I will be graceful about how health systems approach that versus, hey, health is important for everybody. This community has a lot of strengths. Let's go talk to them about what's important to them, what their strengths are. Let's talk about what we see within our system, and then come up together on how we can improve the health of the community. That approach feels different. And as you said, the community knows. The community sees how you approach them and then affects outcomes ultimately. Thank you, Hiroshi. It's been a pleasure.
I really appreciate the opportunity.
Thanks again, everyone, for joining me on another episode, Healthcare for Humans. If you liked this episode, as always, my ask to you is please share it with one other person and go to healthcareforhumans.org to sign up to be part of the community. And lastly, thank you to Tessa Chu for helping with the creation and the production of all parts of this podcast. Thanks again. I'll see you next time.
If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Highway to Health podcast, hosted by Jeremy Quinby, provides guidance, quality resources, and inspiration for anyone seeking wellness in mind, body, and spirit. There's an episode that you should check out called The Value of Our Emotions, where Jeremy helps listeners understand the role emotions serve and what we can learn about our present state by staying attuned to them. Check out Highway to Health podcast on your favorite podcast platform or visit healthpodcastnetwork.com.